honor to present Dr. Michael Ho. He is an associate professor in otolaryngology at Georgetown University School of Medicine and is board certified in otolaryngology, head and neck surgery, and neurotology. He's also a surgeon scientist at the National Institutes on Deafness and Other Communication Disorders at the National Institutes of Health, where he researches auditory development and restoration with a focus on hearing instability disorders. Prior to his arrival at Georgetown, he completed a neurotology fellowship at the prestigious House Clinic in Los Angeles. He currently serves as the co-director of the MedStar Georgetown University Cochlear Implant Program, as well as the director of the Washington, D.C. Veterans Affairs Hospital Cochlear Implant Program. Welcome, and we're looking very much forward to your presentation. Dr. Ho, I will turn it over to you.
Well, thank you for having me, and thank you everyone for being here. I'm going to share my screen. Hold on. Okay. So, can everyone hear me? Viola, is it? Okay, good. All right, so thank you again. And I'm going to talk a little bit about cochlear implant candidacy and how it's changed over time. And I think we used to see patients who had long been without benefit from their hearing aids, but now times are changing and criteria have expanded. So I just wanted to give the audience a little bit of a flavor in the talk today about how things have changed and what current criteria are. I have no disclosures. Really, I think the reason many of us do this is because we really care about the patients, that this work really drives us from kind of a vocational aspect. And our team that we've built over the last 5-6 years since I've been here at Georgetown has grown. We have 4 cochlear implant audiologists and 2 otologic surgeons, including myself and Dr. Jeff Kim. And one of the things you'll notice is that we really are highlighting our audiologists, because while both Dr. Kim and myself do the surgery, the hard work comes from both the patients and really the hours that our audiologists put into working with each of our candidates. And I think that it's really important to highlight their efforts because none of this would be possible without the team that we've assembled together. So briefly, some of the things that I hope to impart to everyone today is to be aware of new referral criteria for cochlear implant candidacy evaluations, to be aware of the expanded candidacy criteria for what's broadly referred to as electroacoustic cochlear implantation, and to be aware of indications for cochlear implantation in patients with single-sided deafness. So I'm just going to begin with an example. This is a gentleman from a few years back who came to me with progressive hearing loss for the last 15 to 20 years, had declining benefits from his hearing aids. He mentioned, one of the first things he mentioned to me was that he wasn't able to hear his grandkids and he really wanted to be more engaged with them. He really had some trouble with hearing, and these were his candidacy test scores here. So he understood about 40% of the words that were said to him in quiet, and on another test in noise, could understand even less. And this was pretty similar on both sides. So, the question is whether, was this gentleman a cochlear implant candidate? And we'll return to him towards the end of the talk. And this is another woman who came to me a couple years back, who had progressive hearing loss since she was a child, had a possible ototoxicity contribution to her hearing loss, had really been appropriately aided since childhood, but had increasing difficulty at work in really what is considered to be a high security federal job for her. So, she was really struggling at work. And this is, what her hearing tests look like. So this sloping loss and just the difficulties that she relayed to me. So she was right here. Her word understanding abilities were about 50 to 60% on either ear on a basic hearing test. So these are some of the range of patients we see, but I just wanted to give you a flavor for that. And I'll return to both of these patients at the end of the talk. So, one of the questions that I think I got beforehand was, what are the barriers to why, for the uptake of cochlear implantation in our population? And if we look at the US, not considering outside, and Laura, I'm sorry that I didn't address take a worldwide perspective here, but we have about 40 million individuals with hearing loss in the US, and of those individuals, about 1.4 million of them have a severe to profound hearing loss. And it's estimated that we have about 100,000 cochlear implant recipients in the US, and about 7% of those are adults, and about 35% of those are children of this 100,000. So, why is it that we aren't closer to this 1.4 million? We're really kind of on the lower end. And, I think many of us in the field believe that awareness of the criteria or education is probably the #1 problem. And even amongst my own specialty, there are otolaryngologists who might not be aware of the current criteria because they have changed. And so, taking a deeper dive at this, one group really tried to look at what are considered barriers and drivers to cochlear implant uptake. They looked at cochlear implant patients, cochlear implant candidates who went forward with a cochlear implant, and cochlear implant candidates who didn't go forward with a cochlear implant, as well as audiology and medical professionals. And they came up with, they did something called concept mapping, which was basically looking at statements from each of these groups of individuals and putting them into areas where, concepts, and grouping them into either barriers or drivers of uptake. And one of the things that, and this may seem really kind of basic, but it's really important to kind of understand these underlying issues, because if we don't really understand where are the areas that we really need to address. So this graph shows the scores, so to speak, and they separated them into, the higher scores would be drivers, and the lower scores would be the items that are considered barriers. And the main takeaways of this is that really external influences and uncertainties from kind of candidate standpoint. So those are what drive, or what really serve as barriers to individuals pursuing these treatments. And so one of the takeaways of the study is that we in general need to improve awareness of cochlear implants and criteria and education among non-implant professionals as well as patients. We need to develop tools to identify candidates and communicate cochlear implant management options effectively and to patients or to individuals who aren't in the field. And so I thought this study is really nice in that it kind of breaks some of those barriers and drivers. And some of these make perfect sense, but it's also being able to show this in a very very easy to grasp format. So the first thing that I really want to address is, when should you or your referring doctor think about referring for a cochlear implant candidacy evaluation, and really who has a good chance of being a traditional cochlear implant candidate. And some recent studies have looked at just a basic audiogram and how do you look at that and what is predictive of a person's chance of being a candidate. So this is a recent study that came out from Terry Zwollen at the University of Michigan. They have a well-established cochlear implant program. And what they did was they looked at all their patients undergoing cochlear implant candidacy evaluations. And they were looking at candidacy determined by traditional criteria. So I'm going to show you that in just a second. So they looked at candidates and non-candidates. They had a relatively equal number. And their aim really was to determine what preoperative audiometric characteristics in patients would who qualified for cochlear implants, basically to look at those characteristics and develop a set of referral guidelines for traditional cochlear implant candidacy. Because many patients who get their hearing tested outside, they don't go through, you don't go through the extensive testing that you go through initially for a cochlear implant candidacy evaluation. So the need was to really figure out who on their standard audiometric test, who would likely be a good candidate. And so they focused on unaided pure tone averages of the better hearing ear and the highest unaided word recognition scores. So really they tried to look at the whole patient, okay, and from a measure standpoint. So looking at their best scores and seeing which of those patients would kind of meet criteria. So this is the traditional adult cochlear implant candidacy criteria. These are patients with bilateral, moderate to profound sensory neural hearing loss. So this is in the yellow here. So often you'll see kind of sloping loss here. And their best aided sentence score is less than or equal to 40%. So that is based on more extensive testing that's done in a cochlear implant candidacy evaluation. And so what Terry Zwollen and her group at the University of Michigan did was they looked at those pure tone average, the better ear pure tone average, and they looked at the better ear unaided word recognition score, and they tried to see who met criteria. So they picked a threshold because what they wanted to do was they wanted to catch all the cochlear implant candidates, and they wanted to find a way to make it so that they could effectively develop a referral pattern, referral guidelines. So they were looking at what threshold would most of the candidates be referred, and based on their data, they found that patients with a pure tone average of basically greater than 60 decibels, so that's in that sorry. So they'd be in here, okay? And a word recognition score on their standard hearing test less than 60%. Those would be patients that would likely meet cochlear implant candidacy or did meet cochlear implant candidacy. And this is looking at it another way, just looking at cumulative percentages. And basically, if they took those criteria, they found that for the greater than 60 dB, they caught about 95% of their candidates, and under 40% or under 60% word recognition score, they caught about 92% of their cochlear implant candidates. And so taking those together, what they found is that with these two criteria, they could detect or had a sensitivity of about 96% in terms of, so pretty sensitive, and in terms of detecting cochlear implant candidates. And they had a false positive rate about 34%. So what that means is that about 34% of patients might have been referred who weren't candidates. But I think that many of us think that that is an acceptable rate because it often gives us a way to better counsel those patients when we know what situations they struggle in, because a cochlear implant candidacy evaluation can also serve as a progress report of some kind for us to identify patients who are struggling and identify situations in which they're struggling. So it often gives us more information and helps us counsel these patients who are struggling to hear despite the use of their hearing aids. So in summary, we think now that using this 60-60 rule, so a pure tone average less than or worse than 60 dBs in the hearing level in the better hearing ear, and a best unaided word recognition score of less than 60%, that's a good time to think about having someone be evaluated. It may not mean that they're a candidate right away, and just because you meet audiometric criteria doesn't mean you're necessarily a candidate, but this is a good way to screen and a good way to begin the process. And I think I want to emphasize that this is a process. It is a process where you're working with a team who's invested in your progress to hear better. So I'm going to shift gears a little bit and talk a little bit about what challenges current cochlear implant patients face and why our criteria have expanded. So why should we care about hearing preservation in cochlear implant patients, and what are the benefits of earlier implantation for these expanded indications? So we know that cochlear implant patients still have challenges. There's still some challenges with understanding speech in noise and complex listening conditions. You do improve in those areas with the cochlear implant, but it isn't necessarily restoring a patient to their abilities before they had hearing loss. And the other thing that we find is that, and patients often tell me, is that music appreciation and tonal language perception can be challenging with a cochlear implant. And the other area that patients with cochlear implants have some challenges with are in sound localization. Now, patients with one cochlear implant do better. Patients with two do better than one, but there are still some areas where a patient may not entirely say, they'll be able to tell which side, but they won't always be able to tell kind of the exact direction. So there are challenges to that, and it's one of the reasons that we have found is that that patient, in terms of implanting patients earlier, what we found is that these abilities have improved, and our ability to save or preserve low frequency residual hearing augments the ability of a cochlear implant patient to accomplish these goals. So what we found is that these patients who were able to preserve hearing in, they have improved speech understanding and noise when that's possible. There is better music appreciation, albeit it's not the same, but it's better. And the low frequency residual hearing also aids in these patients' ability to localize. And we think that has something to do with the way the brain processes that information. And we refer to that as part of this as temporal fine structure, basically being able to sort out different signals in the brain and getting a little more information. So looking at patients now and really what have become really modern cochlear implant candidacy criteria, who is currently considered a candidate now? So we all know, or at least I think many of you know, that a cochlear implant is inserted into the cochlea. And the cochlea is this fluid-filled structure. And they're designed to bypass those hair cells here that that patients lose over time when they lose hearing, and they're designed to directly stimulate the auditory nerve. Okay, so that is for how for many years a cochlear implant has been designed to work. Now, again, this is traditional cochlear implant candidacy. So now let's look at this, but we have many patients who don't quite fit this yellow area and are maybe in more like this pink area in some respects. And these patients, we notice, often complain to us that they're still struggling to hear with their hearing aids. And it's for this reason that really the field has moved in these directions to find better ways to provide solutions for these patients. So one thing I want to say right now is that all modern cochlear implants from all three manufacturers have the potential to take advantage of both acoustic and electrical stimuli or signals. And this depicts basically the three manufacturers and when they approved pieces on the outside use of acoustic stimuli. So modern cochlear implants function both as the traditional cochlear implant as well as a hearing aid all in one. And this has become possible surgically with standard length electrodes because of advances in technology. And hearing preservation with standard length electrodes has been made possible by these slimmer and more atraumatic electrode designs offered by all the companies at this point. So currently there are 2 FDA approved electroacoustic stimulation devices, one through Cochlear and one through MED-EL. And Advanced Bionics has made their acoustic ear hook commercially available, in effect making electroacoustic stimulation clinically available for all their patients too. So many of us use all 3 devices to accomplish these goals. So for Cochlear, they call their electroacoustic stimulation criteria hybrid hearing. And they include a wide range of patients who are candidates for a hybrid hearing cochlear implant. And hybrid hearing has come to include not just short electrodes, but standard length electrodes using the the external processor to gain both acoustic and electrical information. And so we're looking at normal to moderate low frequency hearing loss in the implanted ear and a severe to profound high frequency sensorineural hearing loss in the ear to be implanted. So kind of a hearing loss that runs in this area here. The contralateral ear, so the better ear can't have a score, has to have a score less than or equal to 80% in terms of the word recognition, okay? And the implanted ear has to be somewhere between 10 and 60%. I think and I'm gonna summarize this at the end, but the real key here is a sloping sensorineural hearing loss, limited benefit from appropriately fit bilateral hearing aids. And one of the things we often talk to our patients about is, do you struggle with using a phone in that ear? That's often a good kind of indicator that it might be worth looking into an evaluation. So MED-EL has their criteria, and it looks very similar. This sloping sensorineural loss and this word score or word recognition score under 60%. One of the reasons why we as a field have moved to standard length electrodes in a lot of these cases is that we have an aging population, and there are changes to your hearing that occur with age. And so over time, some of your residual hearing can change over time. And so we're pretty careful about who we offer short electrodes to in this case, because we also want to make sure that there's no instability in that individual's hearing. So that is something for us to consider. And so what we think about is that what if your residual hearing goes out over time, you're still going to benefit from having electrodes in place in those locations eventually. So criteria, summary, just summarizing these criteria: patients with a sloping sensorineural hearing loss, a normal to moderate low frequency loss, and a severe to profound high frequency hearing loss. The CNC score is something that we look at in our testing. And that's so patients with less than or equal to 60% in the ear to be implanted, and really limited or declining benefits from hearing aids. So I wanted to touch on single-sided deafness and asymmetric hearing loss. These are two recently approved indications for cochlear implants, and they're FDA approved fairly recently. So insurances are slowly getting them onto their policies. And as one of the being involved in our American Cochlear Implant Alliance, one of the advocacy points is to try to ensure that more insurers get these on their policies. And really often as is the case, once Medicare gets these on their policies, these will become more widespread in terms of coverage. So, but we've been doing it as a program off-label for a number of years prior to this. And so, like many of our colleagues across the country, and this was done on a case-by-case basis. So who is considered a candidate now according to the FDA approved criteria. So before I go into that, just to give you an idea of how pervasive a problem this is among our population, we have about 66,000 new cases in the US a year. That's about 5 to 27 per 100,000. We're talking about an affected ear that has a moderate to profound sensory neural hearing loss, and the normal or non-affected ear has hearing that ranges from normal to mild sensory neural hearing loss. Generally, candidacy for a cochlear implant has included patients with more profound hearing loss. That's sensory neural, unilateral, and asymmetric. Now, asymmetric hearing loss, you can think of as patients who have a little bit more hearing loss on their better ear, but still do well, but have a fairly non-useful ear on the other side. And why is it important to think about single-sided deafness? So patients with single-sided deafness struggle with perceiving speech and noise. They complain of decreased quality of their hearing. They lack sound awareness to that poorer ear. Some patients will complain that they feel unsafe. They can't hear where sounds are coming from and worry about simple things like crossing a street. And one of the other things that we notice amongst these patients is that they often complain of increased need to concentrate or increased auditory effort and fatigue. So they're really working hard. The other parts of their hearing system are really working hard to get them to function well in the world. They know to reduce quality of life, and they complain of tinnitus. So let's talk a little bit now about cochlear implants. So these are the new criteria for, or FDA approved criteria for sudden hearing loss and asymmetric hearing loss, which is AHL. So these are FDA approved for anyone 5 years or older. You have to have a severe to profound sensory neural hearing loss in the affected ear, and anywhere from a normal to moderate sensory neural hearing loss in the better ear. So this red shaded area here is where the good ear could hear in the range, and this is the range at which the affected ear would be hearing at from their hearing test results. So, and again, the FDA insisted on really making sure that these patients had a limited benefit from appropriate fit unilateral hearing aids in the affected ear. And they define that as a less than 5%, less than or equal to 5% score on a word, a speech test in the ear to be implanted. So for adults, it's the CNC score, among others, and for kids, it's on a developmentally appropriate test, basically a monosyllabic word test. So one of the things to kind of remember here is that one of the reasons that this was really this was really pushed forward is that recently we found in kids that missing one ear has a tremendous impact on an individual's development. And so it used to be assumed that if you have one ear that hears normally, you're fine. But recent research has actually shown that that's not the case, and that there are developmental and cognitive effects of unilateral hearing loss in children. And so this is really pushed these criteria forward. And I think we've benefited from the research done in this area to help push these options or make these options available to our whole population. So I want to kind of put a pause here and say that single-sided deafness cochlear implant testing is not one size fits all. We often have to do other testing to assess candidacy. It's not just simply performing to a test. We have to isolate the ear to be implanted from the normal ear using a variety of different measures. Even though we use the same speech materials as traditional candidacy evaluations, we may need to test in more than one condition or with more than one form of amplification. And we may need to use other forms of measurement to assess benefit. These include questionnaires, testing in noise. In my clinical evaluations, I really take into account the challenges that a patient has and the major complaints and effects on work. These are all things that matter because I think what we really want to know is how we can improve how a patient functions in their world, not necessarily in our testing booth. Our testing booth is a way to develop uniform criteria for how to assess and determine candidacy. But for each patient, their real world situation is ultimately what matters. So again, I mentioned this from the beginning, FDA approval does not necessarily mean insurance coverage. And this is a newly approved indication for cochlear implants. So currently Medicare, where we can obtain prior authorization, it's in these cases where we don't believe that Medicare will currently cover a cochlear implant. However, in insurances where we are allowed to pursue prior authorizations, we have in many cases been able to get a cochlear implant covered for this indication. And we've been doing this for a while, but I think that there's much work that needs to be done in terms of getting this onto language for Medicare. And I think that is in the works currently. And I think one thing that I want to say to anyone thinking about this out there is that even if you don't strictly meet the criteria, but you're struggling with your hearing, candidacy assessments may identify other auditory rehabilitation options and may also provide ways to advocate for you as a patient in pursuing the options that you would like to pursue. So I don't want you to think that just because you don't strictly meet the criteria as you see it laid out here, that many of us aren't willing to advocate for slightly different or slightly less or results that don't necessarily fully meet those criteria if you are truly struggling. Because I think what matters for a patient is, are they struggling to hear with appropriately fit hearing aids, and what can we do to help you perform in the way that you would like to in the settings that you want to be in. So in summary, single-sided deafness criteria are 5 years or older, severe to profound hearing loss in the affected ear, and a normal to moderate hearing loss in the unaffected ear with limited or declining benefit from appropriately fit hearing aids, defined by a score of less than 5% on an age-appropriate speech perception test. So I think that one of the questions that was posed prior, that was communicated to me is, before giving this talk, is what should I expect after cochlear implantation for single-sided deafness? And I think one of the things that we've found is that the speech benefits take longer because you have a better hearing ear that essentially hears normally. So the it requires, sometimes it requires really trying to it's hard to focus on just your cochlear implant ear, but we get our patients to plug their other ear and work with just their cochlear implant ear. But these benefits take about 6 months to a year to accrue, but we also think that some of these benefits take longer and are more subtle. What we do know is that sound localization and tinnitus suppression come earlier in these patients. What these graphs are showing is that really a lot of these patients, this is a series of patients who underwent single-sided deafness cochlear implants at the University of Iowa. And a lot of these patients underwent a destructive procedure in their inner ear for Meniere's disease. But what they find is that they do get an immediate bump in their speech perception scores at about 3 months. But as you notice, these lines, they change a little bit over time. And we see that really almost immediately they get a little bit more benefit with localization. So what you're seeing here is the degrees of error, basically, that they can distinguish where sound is coming from. So the smaller that RMS error is, the better the localization. So over time, patients with single-sided deafness who have cochlear implants do better than what they were when they were before their implant here. But clinically, I think what we notice across our field and really within our cohort in my practice, we see significant improvements in speech perception. It's not perfect, but I think one of the things that we also find is that having a CI in your bad ear helps these patients hear better in their good ear in situations where they are struggling to hear noise. And we know that patients with bilateral implants demonstrate benefits longer term, over up to 3 years out. So we think that we're still early in terms of trying to show benefits for single-sided deafness. While we know that there are benefits here, we think that some of the benefits we don't have all the tests to really show our patients all the ways in that they're benefiting. So, but we do know that we have superstar performers, and we do know that patients who are closer to the time when they lost their hearing, they do better than ones who are further out. And this is just to show that this study used a variety of different implants for single-sided deafness rehabilitation. So there are a number of, we use 3 different manufacturers now for cochlear implants in general. The FDA approved indication for single-sided deafness is for Med-El cochlear implants currently. That being said, we have and others have performed these surgeries with other manufacturers over time, but the current indications as they stand are for Med-El. And these are the results from a recent study using the Med-El array, and these show really continuous benefit with a cochlear implant in terms of speech over time. And they also show continuous improvement in localization. So they're able to discriminate smaller degrees of difference over time. So this is one of the studies from Meg Dillon at UNC that has really kind of pushed these indications forward. So in summary, what should you expect after cochlear implantation for single-sided deafness? Really, you should expect gradual improvements in sound localization, tinnitus, and speech. The speech tends to take longer to improve, with changes occurring over 12 months. A cochlear implant may help improve speech understanding in the better hearing ear. But this process also requires a commitment to continued auditory rehabilitation and training. So I think that there's no replacement for the work that every cochlear implant patient does on their own too. So the last thing I wanted to touch base on was I mentioned that not all patients qualify for a single-sided deafness cochlear implant, but there are other options. And one of the newer options that have made it so that maybe the complications associated with bone conduction devices are less are these active bone conduction devices. And what separates them from the previous devices are while previous devices often stuck out through the skin or depended on some device outside over the skin vibrating and stimulating that device, these current devices are built so that they're implanted underneath the skin, and everything that vibrates or moves is on the internal device. And bone conducting devices basically work by sending sound from the affected ear to the contralateral side. And they're indicated for mixed or conductive hearing losses or single-sided deafness. And they provide sound awareness, but don't necessarily restore binaural hearing. So meaning they don't restore hearing to the ear that's affected. There are two currently approved devices on the market. The Bone Bridge, manufactured by MED-EL Corporation, and the Ossia, manufactured by Cochlear Americas. And they place, with both of these devices, an oscillating mechanism is placed underneath the skin. So in terms of candidacy, as I said, for the Ossia, it's mixed or conductive hearing loss or a single-sided deafness. And that, unlike with a cochlear implant for single-sided deafness, the normal ear really has to be, or the contralateral ear really has to be quite normal. So your hearing in your contralateral ear would have to be in this range really to be considered a standard candidate for one of these devices. The advantages are that there's limited feedback and there are reduced safety issues and complications resulted due to skin complications mainly. For the Ossia, what separates it from the Bone Bridge is that it's only compatible with MRI if you remove the magnet. So that is one downside to that device. For the Bone Bridge, it has the same indications as the Ossia. The one exception, I think one of the advantages here is that it's not a disadvantage actually, but it's actually MRI compatible without surgery. So you can you can use this device and have an MRI without worrying about it. So in summary, these active bone conduction devices are indicated for mixed or conductive hearing loss or single-sided deafness in patients 12 years or older. The mixed conductive hearing loss indication requires bone conduction thresholds that are less than or equal to 45 to 55 decibels in the speech range. And the single-sided deafness indication requires normal hearing in the unaffected ear. So if you take away only a few things from this talk, I hope that you remember that the 60-60 rule for when thinking about referring for traditional candidacy, cochlear implant candidacy. So an unaided pure tone average in the better ear, worse than 60 decibels, and a word recognition score less than 60%. Criteria for electroacoustic or hybrid hearing CI are sloping sensory neural hearing loss with a word score less than 60% in the ear to be implanted. And consider a single-sided deafness CI evaluation if someone is older than 5 years or older and has a unilateral severe to profound sensorineural hearing loss with limited or declining benefit from appropriately fit hearing aids. And finally, active bone conduction devices may be an option for patients who do not qualify for an SSD CI. And I'm just going to return to a couple of the patients that we talked about in the beginning. This is a patient, that 69-year-old gentleman. He wanted a full-length electrode. He was interested in hearing preservation and wanted the ability to pair his cochlear implant with his hearing aids. He chose to proceed with the Cochlear Corporation device. We implanted a 522, which is a slim, straight electrode. And what you see is that this is his ear before surgery, and this is his ear after surgery. So we did a pretty good job of preserving his hearing. And he's done quite well. And his progress with the cochlear implant has been steady. And this other patient that I discussed, she was the one with history of some ototoxicity as a child, had some issues with hearing at work. And again, she was a little concerned about losing her residual hearing. She wanted to be able to hear her child at night. So we talked about this, and she chose to proceed with a full-length electrode. She wanted something that was MRI compatible. She happened to have some other disease that needed to be monitored with an MRI. Now, at the time, Med-El was the only MRI compatible device. Now all manufacturers are MRI compatible without any kind of wrap. And she was interested in hearing preservation. And I kind of want to point out that I never overpromise here. Even though our results are pretty good, each patient is a little different. And so, but we've done quite well, and she still uses her acoustic component to her cochlear implant and really finds that she benefits from it at work. So, and this is her over time. You see that this is her activation, and that her results with her implant over time, while they've changed a little bit, she's largely preserved this low frequency hearing and continues to do quite well. So with that, I'd like to stop and open for any questions. I will exit my screen share.
Russell, I saw that you had entered a question early on, and then after you, Vera. So Russell first.
Could I think I probably posed the question prematurely because I think it's been answered. But okay.
I'm looking at it. So Russell, so you said, does a traditional
No, I was really looking at definitions of what you meant by traditional there, and I think I understand what you're saying from what you said after I posed the question.
Yeah, the traditional candidates are patients who don't have a whole lot of residual hearing to preserve. And but really effectively, now you see that whole range of on the audiogram, we can really offer a cochlear implant to patients in that range. So it's just a representation of how much candidacy has expanded to.
Thank you.
And
Vera had a question for you. It's in the chat box.
So Vera, you asked about, can modifications be made in a hybrid implant if a recipient loses most of her natural hearing in that year? And yes, it can, because one of the reasons why we think about this and we often advocate for standard length electrodes is that in the case that you lose your hearing, we can still use those electrodes, actually. And even in the cases of patients who underwent these shorter electrodes, very few of them had to be reimplanted historically. And I think one of the things that I think everyone has to keep in mind is that the brain remaps to where those cochlear implant electrodes are. So if you have 8 electrodes in and they're in a certain location, okay, your brain will remap all those frequencies to where those electrodes are. So it's possible for your brain to adapt to that, okay? And but one of the things we're finding about our bilateral recipients is that we want to try to match the frequencies between the 2 ears. And so it helps for us to put in a standard length electrode because we can actually adjust the electrodes in terms of what speech frequencies they're encoding, and we can try to match them between the ears. So that's something that we actually now actively pay attention to. And I get post-operative CT scans that are focused on those electrodes so that we look at that. And it's something that our field is doing pretty actively now. At least we're starting to do more than on just a research basis.
Other questions or comments?
Vi, I just raised my hand here.
Go ahead.
Okay.
So let me ask this, given what you were just saying, I'm a recipient. I've had mine since 2010, and I've noticed that when I had an upgrade, it really, the processor really made a significant difference. So my question to you is, are the same kinds of improvements happening on the internal piece? Or do you expect to see, do you see or expect to see changes and improvements in terms of, you talk about frequency response. My understanding is there's a limit to how much information those electrodes can give us. Are we becoming more limitless in our expectations of what those electrodes can give us over time?
I think we are trying to use, I don't think we use all the information that we're getting, to tell you the truth. I think that we're trying to use more of it and take advantage of all the information that we get. What you pointed out about the new processor improving how you hear, it's those changes in programming that are happening, those advances that are really also helping us, our patients hear better. In single-sided deafness, I think one of the issues is that we don't really know the optimal way to encode all that signal when you have a good ear, okay? And so we have those programming changes are being explored right now. I can tell you that recently, I have a collaboration with a group at the University of Maryland and Walter Reed, looking at both single-sided deafness and bilateral cochlear implant speech processing. And what we find, not only do we find that matching on the basis of location through CT helps, but we find that changes to how we program those implants affect speech perception. So we know that there are still a lot of things we don't know, and I think that patients like you are going to get to take advantage of those insights as they become incorporated into these clinical processors. And I think I think that's the beauty of this field, is that you have a lot of competition, and the patients benefit from it in the fact that all the manufacturers want to have these capabilities on. So as soon as they're able to, get these approved, they try to get them on, because we're trying, and everything is designed so that the upgrades happen on the outside, but that internal device is not going to change, or that internal device is still going to be compatible with the updates on the outside. Okay. So I suspect that even with, your device as it stands, 10 years from now, you'll have a new outside processor that will probably help you even more than it does now.
Paul Silverman?
Yes, doctor, you mentioned that tinnitus, I have single-sided deafness along with tinnitus and just the deaf ear. And you mentioned that tinnitus can be improved with a cochlear implant. Is that universal? Are there any data on the percentage of patients that have improved tinnitus?
Yeah, so, I think actually single-sided deafness cochlear implants were done in Europe initially, principally for tinnitus improvement. A large, over 50% of those patients experience relief. I'm not telling you that it goes away. I have my own single-sided deafness patients, and what they tell me is that it's better when they're wearing the implant. That I have a high-functioning kind of executive who was incapacitated by his tinnitus, and he says that has been one of the biggest benefits of getting his cochlear implant. And while I can give you percentages, but I can't tell you that you as a patient are going to be the one, you're not a percentage. And that's so I do think that a large percentage of our patients with cochlear implants in general experience relief from tinnitus.
Okay.
Okay, I actually have a question. I was implanted on my right side in January. Best decision I ever made. I was able to follow your presentation and only reference the captioning. That is a life changer for me. I was unable to distinguish speech at all. However, that said, I was one of those people who had an audiologist in Pennsylvania before I moved here who actively discouraged me from pursuing an investigation of cochlear implant. I have to say, she implanted in me a fear of the surgery, and then just started saying, in my position, there was so much more that hearing aids could do. And one of my frustrations was I kept trying different hearing aids, and I was frustrated with myself. Why couldn't I respond? Why couldn't I do better? And even when I went for my evaluation, I was almost, I don't know, I had very low expectations. I thought, this is just, who knows, you know, blah, blah, blah. This has been an absolute game changer. Like I said, I'm still new to the process. I can't believe the improvement I'm sensing already. So my question is, how do we reach out to so many of the audiologists who appear to be hesitant to encourage patients to pursue an evaluation at least? I should have had this done 10 years ago.
So it's a very good question. And I think that we're involved on many levels with trying to do that. And as a field, there's presence at national audiologists meetings. And so all audiologists have to do continuing education like we physicians have to do. So there are efforts to do that. There are, you know, efforts to partner with local audiologists to do cochlear implants. So it's not just my team that is doing the cochlear implants here now. I work with several different groups of audiologists now. And, you know, in this way, some of these patients get to keep their original audiologists, you know, and I think in the end it's less frustrating for some of these patients and audiologists, because they're not banging their head against the wall about, why am I not benefiting from the hearing aid the hearing aids that I keep changing to? And instead, you know, we're going to try this. I have a relationship here. And so we pick those relationships, we work on developing them, but that takes time. And I do think the public's awareness is part of that. And so we have a lot of work to do, is the short answer. And I don't think that we're going to have less work to do. I think we're just going to have to keep working at it. And my strategy is usually just to be a direct communicator with the audiologists that send me patients. And it seems to work. And I think we all do our part. I don't think that it's going to be any one particular thing, but I think education initiatives and advocacy and public policy changes are going to be happening as we go on. So we'll see.
Thank you. And Lara James has a question in the chat box.
Yes. So Lara, you asked, am I operating on SSD candidates who were born with profound hearing loss in that ear, and how the results been? And I will say that generally patients who are born profoundly deaf at birth in one ear, unless we're talking about implanting them when they're children right away, generally adults we are less likely to recommend that option, because we think that the benefit from that is not, we think that the auditory pathways have changed in the brain over time, and that a patient with that kind of loss in that situation is less likely to benefit. We think that patients who benefit from single-sided deafness CIs are ones who are more recent to their loss, usually less than 10 years. I think it's, yeah.
Have you done it at all there, or you've done it and they've not had such a big benefit?
I have done it, actually, and I think that those patients, it's not that they don't get some benefit, to tell you the truth. what they get are sound awareness and localization. Okay, they don't get speech.
Not at all.
Meaning those patients really don't get appreciable benefits in terms of speech. And it's not to say that those patients aren't necessarily, because when I've done that in those patients, we talk about this, and they're the ones who really push for it. Okay. But we're really upfront about that. And I think that promising a patient in that situation that they're going to be understanding speech is not the right thing to do.
This is Wendy. I'm going to jump in here and talk a little bit about my own experience, because I lost my right ear became profoundly deaf when I was like 2 years old. I don't have any memory of speech in that year. Okay, so but when I received my first cochlear implant, we decided to implant that worst year because it responded better to electrical stimulation. So we went ahead and I finally heard sound in that year after over 30 years of silence. And I have to tell you that even today, I can hear, I cannot understand speech without lip reading. Essentially, and voices and music sound very muffled. It's there, it just sounds really, really muffled. It's not clear. So, but I have to say, I only had that year to work with for over 10 years. So it was better than nothing, but having my other year implanted was like a game changer, because my left ear had better auditory memory, and I know I can understand speech without lip reading in that year. In the left ear, I cannot say the same thing in the right ear. Hopefully that gives Laura some ideas. Thank you.
Yeah, thank you. I think you're a musician as well, aren't you? So it's yeah.
Susan, you had a question about what percentage of
Yes.
individuals born with hearing loss benefit from a CI, and I think if are you talking about adults, or are you talking about children?
Adults primarily.
Adults primarily. So I think that it depends on, patients who've used hearing aids and really have allowed that auditory pathway to be stimulated along the way. Those are patients, even though they are born with hearing loss, those are patients who tend to do well with cochlear implants. Okay. And I would say that, broadly or generally, we think that somewhere between 80 to 90% of patients exhibit really significant improvements in speech after a cochlear implant. And so I think that the chance of benefit from a cochlear implant is quite high in appropriately selected patients, obviously, but yes.
Thank you.
Okay, I don't see any other hands raised. There's nothing else in the comment box or the chat box.
I have a question.
Okay, Lisa.
And actually a couple of comments as well. The first comment is that I'm really glad that you mentioned that this is a process. I think that some of us who saw that movie, Sound of Metal, that was the one thing that really bothered me, is there was no indication at all that this cochlear implant is a process and a journey, and it takes work and working with the audiologist. So thank you for mentioning that. And the other thing I wanted to mention is, I think for me and for a lot of people who are considering CIs, it's sort of like a last resort. And that's how I looked at it. I didn't want to lose my residual hearing. It was kind of like when I reach rock bottom, that's when I'm going to get a cochlear implant. And I think that this hybrid might change that a little bit. but as far as us in the hearing loss community is, I hope that we can try to spread the word and like Vi's experience is, I wish I had done it a lot sooner. Now that I have it, it was such a game changer. I mean, I can't believe what I can hear now with my cochlear implant. The one thing that I like about having the hearing aid in the other ear is that it provides more richness of sound, like more naturalness. So my question is if I were to get a second cochlear implant, would I be able to get the hybrid, even though I have a traditional implant in the other ear? Or would you recommend getting the same?
No, I think if you have hearing to preserve in that ear, we are going to do everything we can to preserve that hearing. And I think even when I don't have much hearing to preserve, I do the same thing. I try to preserve structure because we think that matters, even for patients who don't have a whole lot of residual hearing. What we know is that if we can keep the implant from causing trauma within the cochlea, sometimes even then the speech benefits are just better. But we're, as a field, going to strive and choose to do hearing preservation surgery almost all the time, unless there's an anatomical reason for why we need to consider something else. We almost always try to preserve hearing.
And it sounds like even with traditional, with a full length electrodes, that you're able to preserve hearing more now, I think.
Yeah, those electrodes are thinner. They're less traumatic. They're just better at doing that now. And there's still a lot of things that we're doing to try to improve that. We've got some new techniques on the horizon, like intraoperative electrocochleography that Oliver Adunca's group has pioneered, and we've started using. And some of these measures are going to be incorporated into widely clinical available devices as we move forward. So I think these are all things that we are looking at ways to improve. There's talk about a robotic cochlear implant insertion. Maybe taking my job out, so to speak, a little bit, but not quite. But there's definitely some advancements down the line that we have definitely been talking about, and working on.
All right, thank you. I think at this point, we're about 5 minutes before the noon hour. I don't see
There's a
any
question, I think Manju.
questions or
Yeah.
anything?
Actually, I have a question because my hearing loss is because of my mom, heredity, and it came when I was about 60. But since I was in denial, so I didn't had any help. So it went pretty bad, and right now I'm pretty severe. I have a very severe, hearing loss. And sometimes the hearing aids help me, sometimes it's not. But I have consulted my audiologist a couple of times, even my ENT, but they don't think that I'm a candidate for CI. But sometimes it's very frustrating. I can't hear with my hearing loss. So I don't know what to do.
So I would say that I don't want to speak badly about anyone here. I just kind of, if you would like I would advocate that you get an evaluation with an otolaryngologist that performs cochlear implants and their respective team. If your current otolaryngologist does not do cochlear implants, I would say that they might not be aware of all the criteria, and also in certain cases, there are situations, like I said, where some specialized testing happens, and we try to gear it towards the needs of you as a patient. So we may have one team may have a different perspective on that than another. But what really matters is your difficulties, okay? And I think I would urge you to seek out potentially, if you want, a second opinion to get a different perspective on that.
And I would second that, Manju, because my experience was the same as Vi's, was that my audiologist did not encourage me. I went to her, and then I remember getting testing with her after I said it, and she was very dismissive. She's no longer my audiologist. So I think there is a problem because cochlear implant audiologists and hearing aid audiologists are separate. And once that audiologist loses you to a cochlear implant, they lose out on a client. So there's an inherent lack of incentive for them to refer people for cochlear implants, I think. Although, again, I've met others, as Dr. Hoa has said, who are wonderful, wonderful audiologists, are ready to refer people when they're needed. So I don't want to paint a broad brush, but I do want to say that there are audiologists out there who just, who really see their own benefit more than they're really looking out for their patients, which is a shame. But it's true. So get a second opinion. It's possible you're not a candidate. I mean, I don't know, but it's really worth trying it because, as Vi said, she could have benefited 10 years ago. I am not a poster child. I'm more like Wendy, where I have muffled sound, but I love it because I am bilateral for the first time with a hearing aid on one side. I love it. So check it out. I mean, find it out. It's really worth your time.
Okay, thanks a lot. And maybe I should be able to get some ideologist name from you or so who does that, or maybe I should go online. Okay, thank you.
And stepping in, Lisa, I don't know where we are with the caption. If we wish to continue, I don't know if anyone else has a question or a comment. I know we're a couple of minutes away from losing our live captioner, whom we want to thank again for providing captions. Lisa, what do you think?
I could put that on. So thank you to Sharon. If anybody wants to continue, we can, and I will put on the automatic captions. So thank you very much, Sharon, for being our captioner today.
Yes, thank you.
Thank you.
Any other comments? Or I will weigh in again, just saying, get the evaluation. Oh, how I wish I had just gone for an evaluation earlier. That you can't hurt anything. Can't hurt anything.
Yeah, I'd like to just jump in too, because dealing with Vi with the situation, all this time, it's been very frustrating hearing the audiologist say, yeah, you can do better with this hearing aid or that hearing aid, and watching her do better simply because she lip read, not because of the hearing aids. And knowing that they were saying back at that time that her perception, her understanding was under 40%, she needed to be evaluated then. And what I think I'm hearing you say, and basically everybody else that's chipping in, it doesn't hurt to have the evaluation. It gives you a basic tool to start from. So I'm just so happy that she has it now.
Says my hearing husband, who has put up with all of this for many years.
This is something of a follow-on question. There are criteria, and the criteria, of course, are evolving and becoming, more as we become much more aware of the fact that people with some residual hearing aids can benefit, perhaps in some cases substantially, from implantation. What is, and therefore, I mean, and you mentioned, Dr. Hoa, before, that if you don't quite meet the criteria, look at it and go anyway, because very often, if you're fairly reasonably close, the center can make a case for implantation, even if you don't strictly meet the criteria, as presently defined. I'm just curious about how often this happens. How often, I mean, what percentage, if you will, I mean, I don't know if there's any data on this, of cases, of people who haven't quite met criteria where the case has been made that yes, criteria or not, this is a case, where a patient can benefit, and that case has successfully been made to insurance companies.
I can tell you that we're pretty successful at that. I tend to find that, a lot of our patients come in with a test that, they might have had slightly different parameters in which they were tested. And when we perform our testing, sometimes we find that they frankly do much worse than they actually tested out on the outside. And I've come to have a pretty good sense for when my referring audiologist is spot on and when they might have missed something. And I'm never, it's never anyone's fault. It's just about trying to do what we can do to help that patient in particular. So we, and it's one of the reasons I spend a lot of time trying to figure out what are those patients struggling, what situations are they struggling in? Those kinds of things help when we advocate for patients. And so that's exactly correct. Real world versus booth. I think it's totally the thing that we focus on. We're focused on you in your environment. Our testing is a means to an end. And we have, we sometimes use slightly more difficult testing to justify candidacy, but it's based on the patient's struggles and challenges in their own environment. We never push. If a patient isn't ready, they are not ready. This is a process, it's a discussion. The evaluation is a starting point.
Thank you.
All right, any other comments or questions? All right, Dr. Hoa, I know that we all thank you so much for that wonderful presentation. I even learned more today than I thought I had learned going through the process so recently. And I'm joining with everyone here who said, if there's a question that you think you might be interested or might benefit, don't be a hardhead like me. Go for the evaluation and then take that as your starting point and continue there. This has just been so informative and helpful, even though I've just recently gone through the process myself and am continuing to improve. I'm way ahead when I'm looking at your charts. I'm so delighted with where I am already. And I get pretty clear hearing. I'm not having much muffling at all, so I'm doing well. I must say that when I went in, I said that I would only ever consider one CI. I did not want to think about both ears. And within 2 months of having received this, I was talking to my husband and I said, we'll see, we'll see, because this has just been so wonderful and so life-changing. And I think Lisa mentioned the movie Heavy Metal. I think that did a lot of damage personally. If I had seen that, I saw that right after my surgery before I was activated. And I said to Ted, if I had seen that before my surgery, I really think it would have caused problems for me. And I wish somewhere along the line, professionals could address it. There were some wonderful things about the movie, but there were also some issues that should have been addressed, like the fact that the surgery shown was from years ago. My surgical site looked nothing like what they pictured in the movie. So there's a lot of education still to be done. A lot of fear to be removed, I think. But thank you so much. I think I speak for everyone when I say this was a wonderful presentation, and we truly appreciate your being here. Lisa, is there anything you'd like to say in closing?
No more. Were you about to say something, Dr. Hoa, before we close up?
There have been some very very eloquent responses to the sound of metal. Notably, our director of the NIDCD, who's also a neurosurgeon and neurotologist, Dr. Deborah Tusi. The heads of our American Cochlear Implant Alliance have responded to it, and many other neurotologists in our country. And we all feel the same way, that there is a misrepresentation of the process in that movie. And I think that you know, many of us are trying to educate our colleagues about how unlike the experience of a cochlear implant patient that is. So I think I would refer many to our American Cochlear Implant Alliance webpage, because it contains a lot of information related to insurance coverage and benefits, and really kind of really up-to-date research. I think we really kind of want to make sure that people are informed and educated. We think that's the most important thing. And Vi, I think that you call yourself hard-headed, but you really have been very, very open, as far as I can tell, during this process, and really kind of been, you know, you've done quite well, and I want to congratulate you on your progress. And really, Sue, who was on here, I'm not sure I see her, and oh, there she is, right? She's, you know, I think she's a really good example of someone who, you know, benefited from one side, and then, you know, kind of has started, you know, came to me for her other side, and I think she's also going to do well, and she's, I think patients, it's other patients and people talking to patients like you who are going to really bring our community along too, because I think your experiences matter a lot. And it's the community that kind of is going to bring people forward.
This is Lisa. Yeah, I totally agree with that. Hearing Loss Association has just joined an international group they call it KICA, Cochlear International Alliance for Action. That's probably not exactly what it means, but at any rate, it's a group of people across, because this is a worldwide problem. The adoption of cochlear implants across the world is very low. And people are coming up with creative solutions to advocate for more cochlear implant adoption. But, you know, it just stuns me, because I know that the adoption rate of hearing aids is low enough, but it's even worse for cochlear implants. So we really need, this is an effective tool for so many people that we really need more people to know about it. And we can be the voice. So we're a consumer organization. Everybody here who has a cochlear implant can advocate for them, you know, to others about it, but we'll create a platform as well.
Harold, I saw your, I'm sorry, I saw your message. I will correct, I've got to make a slight correction to my slides, but I will send a PDF version to Lisa and she'll send it to everyone.
Okay, terrific. That's good, because people want to see it. We'll also put it up. Wendy will put it up on the YouTube channel so that everybody else can see it too. So again, I don't want to take up more of your Saturday. I appreciate your being here. Thank you so much, Vi, for directing the show here today. And thank you for everybody who came. So we are taking a break for the summer, but you'll see some emails from us to find out what we're going to do in fall. And now that we don't have to wear masks all the time, maybe we'll actually see each other in person. So thank you again, and thank you, Vi, and thank you, Lisa, for pulling in Dr. Hoa, and thank you, Dr. Hoa.
Thank you for having me. Have a good weekend, everyone.
Thank you.